This is Ramesh Ramanathan. I'm a medical oncologist at the Mayo Clinic, and I specialize in the treatment of pancreatic cancers. Today, it's a great pleasure to have two of my colleagues here, Dr. William Rule and Dr. Jonathan Ashman from the Department of Radiation Oncology at Mayo Clinic. I'm going to start off with a question for Dr. Rule. Radiation is certainly an integral part of pancreatic cancer treatments, and especially after surgery, where in some cases there's a risk of the cancer coming back, where would you recommend that radiation therapy be considered?
So Dr. Ramanathan, that's a great question. So many patients think that despite a good surgery, that there is a very good chance of cure. And in selected patients, we know that there's a risk of a recurrence occurring within the region where the surgery actually occurred. And in those selected patients, we do know that there's a benefit to radiation therapy delivered to that area. And typically that's delivered with chemotherapy at the same time. And this is sequenced in a way that requires very tight multidisciplinary organization, something that we do here at Mayo Clinic in sequencing those therapies so that the patients can get the maximum benefit out of each and one of those therapies, whether it's chemotherapy or the radiation in the circumstance after a surgery.
So certainly surgery is something that we want all pancreatic cancer patients to undergo because that's the best outcome. But when we stage a patient, we have a category called borderline resectable, where we have found out that doing surgery immediately may not result in the best outcome. In that situation, Dr. Ashman, how is radiation therapy incorporated into the treatment planning?
Right, so this is a relatively new category of pancreatic cancer patients who have tumors that are close to blood vessels that can't be resected, and where there's a very high risk that there might be microscopic cells left behind. And we know that if surgery is done up front, these patients are at very high risk for recurrence and unsuccessful treatment. So we've incorporated radiation before surgery in a preoperative fashion in these patients, again, together with chemotherapy, to try to improve their outcomes, select the patients who will most benefit from surgery, and also be able to maximize the success of that surgery. We can also combine radiation at the time of surgery for those patients who are at high risk for microscopic cells left behind with the use of intraoperative radiation therapy. And Mayo Clinic is actually the only center in the Southwest that can offer intraoperative radiation therapy in the setting of pancreatic cancer.
Thank you. And when we look at localized pancreatic cancer, I think the third category is what we call unresectable, where there's very unlikely that surgery can be done because of involvement of the major blood vessels. And at the Mayo Clinic, how do you incorporate radiation into the treatment algorithm?
And so in these patients, again, this requires significant multidisciplinary organization. And for patients who are not eligible for surgery up front, and we don't think that they're eventually going to become candidates for surgery, typically there's a sequence of some chemotherapy delivered, but undoubtedly radiation is strongly considered in an effort to try to control the cancer where we see it on the scan, so in the region of the pancreas. And that is also delivered with chemotherapy. And the intent there is to try to optimize outcomes and to minimize the chance of the cancer in that region that the radiation beams are targeted towards of growing and causing significant symptoms for the patient.
Well, I'm going to ask Dr. Ashman the next question. One of the common questions that come up from patients and families is, what can you expect from someone undergoing radiation therapy? What are the possible side effects, and what can be done to reduce the incidence of those side effects?
Right, so treating pancreatic cancer with radiation is very challenging because of its location in the center of the abdomen, and it's surrounded by intestines, which are among the most sensitive organs that we have, tissues that we have to radiation. And so to try to deliver a high dose of radiation that can give us a good chance of controlling the tumor while minimizing side effects is challenging. And when you think of that location, the most common side effects that we see are things like nausea, because we're treating very close to the stomach, and diarrhea, because we're treating the intestine, small intestine, along with chemotherapy. And many patients will also feel quite fatigued and quite tired from the treatment. Part of that is coming in every day for treatment, and part of that is the combination of radiation and chemotherapy. Some patients may have some mild skin reaction, but this really is quite minimal when we're treating such a organ that's central in the body. So we're not too worried about skin reaction. It's really the nausea, the diarrhea, and the fatigue that we keep an eye out for.
We just talked about the side effects someone may experience while getting treatment. Are there any long-term or chronic side effects?
Absolutely. So we do think about radiation side effects in terms of short-term and long-term. The short-term side effects, which I talked about, like the nausea and the diarrhea, these are temporary. They will build up over the course of the 5.5 weeks of radiation, and then they'll pass by 3 or 4 weeks after the radiation. They'll completely go away. However, there are some potentially more serious longer-term side effects that could develop months, 6 months, 9 months, or a year or so after radiation that we do watch out for, but fortunately happen less frequently. The most serious would be something like an ulcer or a bleed, gastrointestinal bleed in the duodenum or small intestine or stomach, because those are so close to the target. We might also cause scar tissue to form in the region of treatment that could cause a small bowel obstruction. Especially after surgery, patients are at risk for what's called adhesions. After any abdominal surgery, the scar tissue can form and the intestine can kink and block off. If you add radiation after surgery, you can certainly increase that risk of small bowel obstruction. Fortunately, that's not a life-threatening side effect most of the time, but sometimes could require additional surgery. Other more serious long-term side effects or damage to surrounding tissues like liver or kidney or spinal cord, actually very uncommon with modern radiotherapy planning. So we see that hardly at all now.
And radiation therapy certainly has come a long way in the last 20 to 30 years with newer techniques, computer-assisted treatment planning. And we see a lot of new methods for radiation therapy like SBRT and IMRT. Maybe I'll start off with Dr. Rule. You could explain what is SBRT and is there a role for it in treatment of pancreatic cancer?
So SBRT it stands for stereotactic body radiation therapy, and essentially what that means is very potent doses of radiation therapy targeted in a very precise way. The main limitation of SBRT is the fact that it has to be aimed at something relatively small and ideally away from critical structures, as Dr. Ashman had mentioned, small intestine, and that's one of the most critical structures adjacent to the vast majority of pancreatic cancers that we treat. So patients that are eligible for stereotactic body radiation therapy generally fall into a couple categories. There are patients where they may not be eligible for a surgery because of medical reasons, heart problems, lung problems, etc., and patients who are potentially eligible for clinical trials. So this is a new technology. We're trying to learn how to use it, how to best use it, what are the benefits of it, what are the side effects of it, and so patients on a clinical trial. It is a new technology, and I should emphasize that it applies to a very small subset of pancreatic cancer patients. It certainly is a technology that we have available here at Mayo Clinic and something that we use in the appropriate patients.
Thank you. And what about IMRT? I would think that IMRT is more commonly used. And also, what is the usual radiation treatment plan? How many days would a patient undergo radiation therapy?
Exactly. So as Dr. Rule was talking about stereotactic body radiation, giving big doses of radiation only over a few sessions, typically 5 radiation sessions in a week or so. The more standard way of delivering radiation, what we call standard fractionation, is small doses of radiation each day, Monday through Friday, for about 5 to 5.5 weeks. So 25 to 28 individual treatments is a standard way of giving radiation, external beam radiation for pancreatic cancer. The reason for that is because of the side effects, as we mentioned. And when you give small doses of radiation each day, you actually allow the normal tissue to sort of repair itself. And that can reduce both the short-term and the long-term side effects of radiation and allow us to give the radiation with chemotherapy, which we know can improve the outcome. So in the past, we would do what's called three-dimensional conformal radiation, which we would use the CT scan to help guide our radiation, to design our radiation fields. But each individual beam of radiation was uniform. We might come from multiple different angles, like the front and the back and the sides, but each individual radiation beam was a uniform beam. Intensity modulated radiation therapy, or IMRT, is using 21st century technology to shape those individual beams. And in that way, we can actually really paint the dose of radiation and create curves in our doses to try to minimize the high dose radiation going to those surrounding critical structures like the intestine or the stomach or the kidneys or the liver or the spinal cord. And we hope that this will decrease the nausea and the diarrhea and the fatigue that we talked about earlier. We also hope that it will decrease any potential longer-term side effects, such as more serious bleeding in the intestine or scarring in the intestine that can cause obstruction, by minimizing the radiation going to those normal tissues. Potentially, using something like IMRT could also allow us to increase the intensity of chemotherapy during radiation, which could be of benefit both to improving the local treatment as well as decreasing the spread of the cancer outside of where we're treating with radiation, and potentially could allow us to increase the dose that we're giving to the local tumor by decreasing the radiation to that intestine, which is so sensitive to the radiation, and thereby maybe improving our outcomes.
Thank you. So it's certainly an exciting time to be in this field with many new developments, and one of the newer developments that we are eagerly awaiting at the Mayo Clinic is opening of the Proton Therapy Center. Maybe Dr. Rule, what is proton therapy and how does it differ from conventional radiation?
So that will be available in 2016, and specifically protons are a particle, unlike conventional radiation, so what Dr. Ashman had discussed, 3D conformal radiation, IMRT, that uses conventional X-rays. And so certainly there's great utility in those X-rays for treating cancer, and that's been the mainstay of treatment for decades. Protons are a relatively new technology, and essentially using particles which are an extension of the paradigm that Dr. Ashman had discussed with IMRT. So trying to spare as best as we can the normal structures. And instead of shaping the beam, we're using particles and their inherent ability to stop at defined areas to try to minimize the extension of dose through the body and through critical structures, and potentially using protons in a way to escalate the dose of radiation therapy, either in a conventional way, so over many, many weeks of radiation therapy, or akin to stereotactic body radiation therapy, so potent doses over roughly 5 treatments or so. Whether or not protons will bring anything significant clinically to bear is something that is undefined at this point in time. It's a very attractive technology. It's something that we're very excited about. But at Mayo, we're going to make sure that it actually does benefit patients. And so patients, for the most part, will be treated on clinical trials to make sure that we are learning how to best use this new technology. And something also that we will have at Mayo Clinic is something called IMPT, so intensity modulated proton therapy. And it is essentially IMRT, but for protons. And so that is a truly exciting treatment technology, a truly exciting treatment paradigm, but we certainly are committed to making sure that our patients are really going to benefit from it, and that we learn which patients truly will maximize benefit from using protons.
And Dr. Ashman, particularly for pancreatic cancer, are there situations where proton therapy will be used as part of a clinical trial or as a research program?
Well, we're interested in looking at it in many of the situations we previously talked about. So, for example, a locally advanced tumor that cannot be resected but has not spread elsewhere, can we use proton therapy to deliver higher doses to the tumor, which potentially could improve outcomes or cure the patient without surgery, and use more intense chemotherapy by decreasing the amount of radiation going to the normal tissues, which could improve outcome? Potentially, in those patients, they might benefit from using a stereotactic body type of treatment regimen with only 5 fractions, where we'll need protons because of their precision to minimize the dose to the normal surrounding tissue and be able to achieve a safe treatment that way. Others have looked at protons as well in the postoperative setting or in the borderline setting with using more standard, longer course treatment, again, to increase the dose or increase the intensity of chemotherapy. So we're going to be interested in many of those, and we're thinking about different clinical trials that we can exploit the really exciting technology in protons and learn how best to use it.
Thank you, gentlemen, for your time. This was incredibly useful and very instructive, and I'm sure our viewers watching this will find this helpful as well. More information on this topic can be obtained from the Mayo Clinic website.